Hello everybody. Today we are going to have a very important topic in renal pathology for medical students. Today we are going to talk about the nephrotic syndrome. It is a very important topic and you need to pay attention to this very important lecture because you are going to encounter the nephrotic syndrome patients in your clinical practice. Therefore, you need to understand it properly. The presentation outlines: number one, the intended learning outcomes. Then we are going to see the nephrotic syndrome definition, causes, clinical course, and morphology of the minimal change disease, the focal segmental glomerulo-sclerosis, membranous glomerulonephritis, and the membranoproliferative glomerulonephritis. These 4 points are causes of the nephrotic syndrome, primary cause of the nephrotic syndrome. Therefore, you have to be used to, and you need to differentiate between each of them. Finally, we are going to see the complications of the nephrotic syndrome. At the end, you find the quiz and the further learning resources. By the end of studying this session, students should be able to define the nephrotic syndrome and explain its components, causes, and pathogenesis. Define and describe minimal change disease. Define and describe focal segmental glomerulosclerosis. Define and describe membranous glomerulonephritis. Define and describe membranoproliferative glomerulonephritis. And finally, to list the complications of the nephrotic syndrome. Definition of the nephrotic syndrome. Nephrotic syndrome is a manifestation of glomerular disease characterized by heavy proteinuria leading to hypoalbuminemia and edema. This picture may be associated with hyperlipidemia and lipiduria. The overview of the causes and pathogenesis. The causes of the nephrotic syndrome are either primary glomerular diseases or systemic diseases leading to glomerulopathy. These are the main causes, either primary glomerular diseases or systemic diseases. The main point in the pathogenesis is the glomerular basement membrane damage by the immune system results in loss of proteins from circulation to urine. So we repeat again, the nephrotic syndrome is massive proteinuria in the range of 3 to 3.5 grams per 24 hour in adults. The hypoalbuminemia below 2.5 gram per deciliter of plasma, and as a result there will be edema. It is mainly preorbital edema or can be generalized, and it is obvious that the edema is due to decreased oncotic pressure within the circulation, leading to increased production of aldosterone as the stimulation of the renin-angiotensin aldosterone system, leading to absorption of water and salt inside the body, and this water will leak to interstitial spaces and not stay within the blood vessels, therefore leading to edema. There is hyperlipidemia, and the causes of hyperlipidemia are thought to be due to excessive free lipids as a result of loss of the carrier proteins. Another cause for the hyperlipidemia is thought to be the increased hepatic production of lipids due to unknown causes. The lipiduria is obvious. It is due to leak of lipids through the glomerular basement membrane that is already damaged. So here you can see the glomerulus leading to damaged glomerulus leading to loss of protein in the urinary space. The urine in nephrotic syndrome is frothy or foamy, and it is turbid urine and containing large amount of protein. And this loss of protein will lead to periorbital edema or the generalized edema that is seen mainly in the lower limbs. When we come to the causes of the nephrotic syndrome, as we mentioned, we have primary glomerulonephritis or idiopathic glomerulonephritis, and these are the minimal change disease, the focal segmental glomerulo-sclerosis, the membranous glomerulonephritis, and the membranoproliferative glomerulonephritis. And then we have the secondary causes of nephrotic syndrome that include a large list of diseases. Examples of them, or the most common of them, are diabetes mellitus, amyloidosis, systemic lupus erythematosus, drugs, hepatitis B and C viruses, malaria, syphilis, cancer, and heroin. So the pathogenesis and the etiology, the morphological changes, and the clinical manifestations can be demonstrated in this illustration. The basic problem is the abnormal immune response against the glomerular basement membrane. This can be primary, as we said, or can be due to other diseases such as diabetes and SLE or hepatitis or HIV. And this will lead to glomerulonephritis and glomerular basement membrane damage. So this is the major pathology. There is damage. This damage can be due to minimal change disease, focal segmental glomerulosclerosis, minimal change or membranous glomerulonephritis, and the membranous glomerulonephritis. This damage will lead to protein loss in urine, and as a result you find decreased protein in circulation. This will lead to decreased oncotic pressure, leading to escape of fluid from the intravascular compartment to the interstitium, causing edema. There are other complications that associate the protein loss, and these are mainly infections and thrombosis due to fluid loss and the renal failure that can occur as a complication. And then you can find the hyperlipidemia and the lipiduria, as we mentioned earlier. Now we come to the minimal change disease. It accounts for 80% of all cases of the nephrotic syndrome in children and about 10% of nephrotic syndrome in adults. As the name implies, minimal change. So by the light microscope you find normal glomeruli, no change at all. However, by electron microscope you find loss of the food processes of the podocytes. We call it effacement. As you can see in this the illustration, the normal glomerulus, you find the basement membrane, and you find the podocyte, and the podocyte has food processes. When there is minimal change disease, there is loss of these food processes and you find only effacement. This loss of food processes, as you can see here, lead to leakage of protein from the intravascular compartment to the urinary space, and then it goes outside through the tubules. Another picture, you find no difference between a normal glomerulus and a glomerulus with minimal change disease by the light microscope, and when it comes to the electron microscope you find In the normal one, in the normal glomerulus, you find food processes, whereas in the glomerulus with minimal changes, you do not find the food processes. This is more illustration of the same pathology, loss of the food processes of the podocyte. You find effacement, that is to say attachment of the podocyte directly to the basement membrane. So the minimal change disease, or the also known as the lipoid nephrosis, this is an old term, is the most common cause of nephrotic syndrome in children, and you find effacement of the food processes. More pictures of the same pathology. This is a normal one, and this is one with minimal change disease. Another light microscope, there are no change in the glomerulus. These are the tubules. These are the tubules. You may find lipid within the tubules. By immunofluorescence, there are no change. This is normal picture of a normal glomerulus, so there are no deposits of complement or immunoglobulins. Another electron microscopic picture of minimal change disease, in which we do not find the food processes that we know. The clinical course of minimal change disease, it starts insidiously or indolent. It runs slowly course in an otherwise healthy individual. 90% of individuals who respond to corticosteroids, that is to say prednisolone treatment, is the minimal change disease respond very well to steroids. However, there will be recurrent proteinuria in a majority of cases, and they need steroids in order to decrease this proteinuria. We call them steroid dependent. Less than 5% will develop chronic renal failure in 25 years. So the minimal change disease, as you can see, responsible to steroid, and very few cases will go into renal failure. The second cause of the nephrotic syndrome is the focal segmental glomerulosclerosis. As the name implies, focal means some glomeruli, and not all glomeruli in the kidney are affected. Segmental means a segment of the or part of the glomerulus is affected, and not the whole glomerulus. As you can see in this picture, you find this segment affected by disease, whereas the rest is normal, and it is glomerulosclerosis. So just like its name, it is focal disease, that is, some and not all glomeruli in the kidney are affected, and it is segmental, and all the segments are not the whole glomerulus is affected. So it is a glomerulosclerosis, that is to say fibrosis. It is not glomerulonephritis. So it is focal segmental glomerulosclerosis. It is the most common cause of nephrotic syndrome in adults, and it is associated with many secondary conditions such as HIV and the street heroin. So in the focal segmental glomerulosclerosis, it constitutes 30 to 40% of the nephrotic syndrome in adults as the most common cause, as we mentioned, and about 10% of nephrotic syndrome in children. It may be due to immunoglobulins and the complement immune responses. It has insidious onset, that is to say slowly developing, and here you can see that 50% of patients with focal segmental glomerulosclerosis develop renal failure within 10 years. These are the photos that you need to see in focal segmental glomerulosclerosis. You see this glomerulus is affected while this glomerulus is normal, so it is focal. And you see this segment and this segment of the glomerulus affected, and this segment is normal, so it is segmental. So it is a focal and segmental glomerulosclerosis. Another picture of the focus segmental glomerulosclerosis is known as the collapsing glomerulopathy. It has a worse prognosis than the normal one. You see collapse of some tufts of the glomerulus. The glomerular tip lesion is another type of the focus segmental glomerulosclerosis, and it also you see the segment is affected while the rest of the glomerulus may appear normal. In the focus segmental glomerulosclerosis, you find segmental damage, or all the segments of the glomerulus are affected by damage, or the pathology is in these areas, whereas the rest of the glomerulus is normal, as you can see here. This is a normal part, no immunofluorescence deposition, and in this segment and this segment you find deposition of immunoglobulins. So the same applies here. You can see damage in one part of the, or segment of the glomerulus. The third cause of the nephrotic syndrome is the membranous glomerulonephritis. Membranous. And the membranous glomerulonephritis causes about 30% of nephrotic syndrome in adults, but only 5% of nephrotic syndrome in children. It is also associated with drugs, malignancies, systemic lupus erythematosus, and infections. And there is subepithelial deposition of immune complexes. It runs an indolent or insidious course, and about 60% will continue to have persistent proteinuria. 10 to 40% go on to renal insufficiency within 10 years. The pictures of the membranous glomerulonephritis are seen here. You can see thickening of the basement membrane, because the name membranous means the main problem is in the membrane, the main pathology. And you can see here this thickening is due to immune complex deposition in the basement membrane, and you can see it here as spikes and domes. We call it spikes and domes due to upward and downward the basement membrane, as you can see here, and you can see the granular pattern in immunofluorescence. So in the membranous glomerulonephritis, we find these electron dense deposit along the epithelial side of the basement membrane, and not the endothelial side, the epithelial side of the basement membrane. Another picture of the membranous nephropathy, you see thickening of the basement membrane resulting from deposition of immune complexes. Another picture, this is a normal, and this is glomerulus with membranous glomerulopathy, and you can see the deposits of the immune complexes here. In electron microscope, as you may anticipate, there is granular pattern of deposition due to immune complex deposition in the basement membrane. The fourth type of primary glomerular diseases that result in nephrotic syndrome is the membranoproliferative glomerulonephritis. This is number 4 as a cause of nephrotic syndrome, the membranoproliferative glomerulonephritis, and it is also known as the mesangiocapillary glomerulonephritis. It accounts for 10% of nephrotic syndrome cases in both children and adults. And in this type, or the membranoproliferative glomerulonephritis, you find glomerular membrane change, subendothelial deposits, mesangial proliferation, and leukocyte infiltration. So the whole picture is the membranoproliferative membrane thickening as well as proliferation of the cells. These cells include the mesangial cells, the immune cells such as leukocytes and so on. All of them will come to cause damage in the membranoproliferative glomerulonephritis type. So the MPGN can be idiopathic or can be secondary. For example, to SLE, viral or bacterial infections. It has two types. The type 1, that is the majority of cases, 80%, it is due to immune complex deposition, whereas the type 2 membranoproliferative glomerulonephritis is also known as the dense deposit disease. It is due to complement activation without finding any antibody. Here it usually due, it is a problem of complement activation within the glomerular basement membrane, not induced by antibodies. The membranoproliferative glomerulonephritis is persistent and progresses to renal failure, and usually it has worse prognosis. This is a photo of membranoproliferative glomerulonephritis. You can see thickening of the capillaries and the basement membrane, as well as proliferation of the cells. You find too many cells in this photo, as you can see, and you can see the complement and antibody deposition in type 1. In type 1 mainly there is antibody and complement deposition. It gives the granular pattern of deposition. This is the type 1 damage. And in type 2, the main problem is the complement activation without antibodies. This is mainly due to complement activation. More pictures can be seen. The type 2, you find the dense deposit disease within the basement membrane. And this deposition of antigen antibody complexes will lead to damage of the glomerular basement membrane, and this will lead to leak of protein from the capillary site to the urinary space. When you compare this with the normal basement membrane, this applies to all types of glomerulonephritis in which there is antibody or complement protein that causes damage. The average age of the types of the nephrotic syndrome can be seen here. Early on in life, during childhood, you find the congenital nephrosis, and because they are a minority, we did not mention here in this lecture. And then in the age of 4 to 5 years, you find the minimal change disease, and then you can also find the focal segmental glomerulosclerosis. These are the most common causes of glomerulonephritis and nephrotic syndrome in children. And then comes the diabetes type 1 nephropathy around the ages of 30 years as a complication of diabetes type 1. And once again you find the minimal change disease around the age of 40 years, and then we find the membranous nephropathy comes in the 50s or so, and then comes the diabetes type 2 nephropathy or complication of diabetes mellitus. This is also associated with the malignancies or malignant nephropathies as a result of paraneoplastic syndrome and amyloidosis in the elderly. So you can anticipate the causes of the nephrotic syndrome based on the age. The most common cause in children is the minimal change disease, followed by the focal segmental glomerulosclerosis. Other causes of the nephrotic syndrome are uncommon. The complications of the nephrotic syndrome are infections, and this is mainly due to loss of immunoglobulins or antibodies in the circulation, and the thrombosis, that is mainly caused by the loss of the intravascular fluid and other change in the proteins that is associated with the thromboembolic phenomena. And then we find the acute renal failure may complicate the nephrotic syndrome, as we mentioned, particularly in the membranoproliferative type, or the membranous, or the focal segmental glomerulosclerosis. And the chronic renal failure is another complication, as we mentioned, in the causes of the nephrotic syndrome. And as a complication, you may also find the side effects of steroids that we use to treat the cause of the nephrotic syndrome. Steroids, as we all know, are immunosuppressants or immunosuppressive drugs, and we use them in the treatment of the nephrotic syndrome. They may cause side effects, particularly if used over a long period of time. And this is, I would ask you to go through the following slides to revise the conditions, because this lecture is not an easy one and you need to go through it more than once. So you can find the PowerPoint presentation uploaded, and you have to go through it one by one in order to understand what do I mean by the lecture. And then I would like you to write an assignment about the intended learning outcomes. If you understood the points that I taught you here, you are going to write this assignment about the intended learning outcomes. And in the quiz section, I'm going to ask you certain questions that you need to read, and then try to answer by yourself before you see my answer. So you find these quizzes very important. What is the level in grams per ml for serum protein that is consistent with the nephrotic syndrome? Gram per deciliter, I mean, and not per ml. Gram per deciliter, and you find the answer, and then you go through the quiz. What is the difference between the primary and the secondary nephrotic syndromes? You have to know the answer by yourself. And in the fourth quiz, you can see the focal segmental glomerulonephritis, and you find the answer. You can stop the video to read the question and try to answer before going to the next part of the quiz. You can stop the video, read the question carefully, try to give your answer before you proceed to see the answer. Okay. This is a very important illustration that I would like you to see. You consider this illustration as the major glomerular structures and demonstrate what morphological change you expect to find in each of the following glomerulopathies. What do you expect to find in the minimal chain disease? What do you expect to find in the focal segmental glomerulosclerosis? What do you expect to find in the membranous glomerulonephritis? And what do you expect to find in the membranoproliferative glomerulonephritis? Putting into consideration these structures, these are the podocytes, and this is the basement membrane, and this is the capillary lumen, and they are mesangial cells. So in each of the conditions, I would ask you to try to remember what change happened in each of these conditions. These are the further resources for learning. that you may go through. And finally, thanks